Okay, so we'll go ahead and get started, knowing that some folks will join us as we continue. So just to introduce myself, I'm Emily Carter, and I'm an assistant scientist in the International Health Department at Johns Hopkins. And today, Tim Robertson and I will be presenting on our, again, early analysis of the indirect effects of COVID-19 on maternal and child mortality in low and middle income countries. We have a number of LIST team members on the call today who are available to answer questions related to the analysis and using the LIST tool to conduct your own analyses. The tool and support materials, again, are available at LiveSafeTool.org. And we will be recording the webinar, so we'll post that recording on our website, so if you have to jump off the webinar or have colleagues who are unable to join, do that there. And again, please take advantage of the Q&A feature to ask questions as they arise during the presentation, although we will have a dedicated Q&A period after the presentation. Next slide. So just a bit about the motivation for just an overview of what we're going to be handling today. So I'm going to take us through our motivation for the analysis and provide just a brief introduction to the LiveSafe tool, and then I'm going to hand over to Tim, who will take us through the analysis methods and results, as well as our plans for future analyses and how to run your own list analysis. And then again, we'll plan to leave some time at the end for questions. Next slide. So the presentation, again, will focus on our estimates of the potential indirect mortality due to declines in reproductive, maternal, newborn, and child health intervention coverage, as well as increases in wasting related to the COVID-19 pandemic. So the paper was released last week in Lancet Global Health, and we would encourage you to read that paper again if you have not already. Next slide. So just a brief bit of our motivation for this work. So as we all know, the coronavirus pandemic has created a worldwide state of emergency, and countries have shifted their resources to respond to that emergency. And this has the potential to result in the neglect of the provision and utilization of basic and regular essential health services. Next slide. So while mortality rates for COVID-19 appear to be low in children and women of reproductive age, they may, however, be disproportionately affected by the disruption of routine health services. And we saw that, for example, with the 2014 West Africa Ebola outbreak, in which the indirect effects were more severe than the outbreak itself. So based on what's occurred with previous outbreaks and what we've been seeing in this outbreak so far in numerous settings, we anticipate that there is a high probability of disruption to provision and utilization of reproductive, maternal, newborn, and child health services. Next slide. So specifically, we're concerned about interruptions to service provision due to reallocation of health resources to respond to the influx of COVID-19 patients, a reduction in the health workforce due to illness and fatigue, disruption to both the global and domestic supply chains, and the stopping or reduction of delivery of health interventions through campaigns. We're also concerned about reductions in service access due to financial and physical barriers related to movement restrictions and related economic crises. And the reduction potentially in demand for RMNCH services due to fears over potential COVID exposure while accessing care. And so together, these effects would translate into a reduction in RMNCH intervention coverage. And finally, we're concerned about potential increases in wasting due to reduced food security. So the World Food Program recently projected there could be a doubling in food crises. So while the causes for increased wasting rates fall outside of the health sector, which is our primary focus with this analysis, we expect that wasting could have a significant immediate impact on both child morbidity and mortality. Next slide. So with these concerns in mind, we set out to assess if certain hypothetical COVID-19 outbreak and response scenarios were to occur, what would be the indirect impact on maternal and child mortality? So we explored 3 scenarios of varying severity over 3 windows of immediate effect, so 3, 6, and 12 months. And we used data from 118 low and middle income countries that account for over 97% of global maternal and child mortality. We conducted the analysis using the LiveSafe tool, which can model mortality impact related to a change in coverage of over 70 RMNCH interventions and risk factors. And our ultimate goal was to generate realistic, quantifiable estimates as a reference point for decision makers. We've been engaged with colleagues at the WHO, UNICEF, World Bank, and the Bill and Melinda Gates Foundation since early in the project. And we really consider this the first phase of our work. And Tim will speak to some of our future plans later in the presentation. Next slide. So I'm just going to give a quick introduction to the LiveSafe tool. So LIST is a linear deterministic mathematical causal model used to estimate mortality impact based on change in coverage of RMNCH interventions and prevalence of risk factors. LIST is housed within the Spectrum computer software package, and so it's based on demographic projections tied to trends in mortality and fertility. The tool was developed by the LiveSafe team at the Institute for International Programs at Johns Hopkins, along with collaborators from numerous institutions, including both modelers and health area experts. And the tool has been validated in numerous settings. So you can see on the right here, this is an overview of some of the relationships between interventions, risk factors, and mortality within the model. And each of these boxes contains numerous interventions. So this is a snapshot of some of the interventions impacting on child mortality, just again to highlight the complexity of the relationships within the model. Next slide. So how do you go about running a list analysis? So you start by creating a baseline projection for a country or a region, and that's essentially your known health status for a country in a given year. So the baseline projection is based on the demography within a country, and that's pulled from the World Population Prospectus. And for child health, we pull mortality estimates from IGMI and partition deaths by cause using MICI data. Then we input current levels of intervention coverage and risk factors based primarily on data from population-based household surveys like the DHS or MICS, or joint WHO-UNICEF estimates. And these factors together create an envelope of deaths by cause for an established intervention coverage level. And we can use this to nail down the potential for lives to be lost or saved attributable to a change in coverage of an intervention or risk factor. So then we can take that baseline and scale coverage either up or down. So often we're modeling what would happen if you introduced a new intervention, like a new vaccine, or scaled up coverage of existing interventions. However, in this analysis, we looked at a reduction in coverage of numerous interventions and an increase in the prevalence of wasting. So once you scale up or down that coverage, you end up recomputing mortality. Next slide. So we take that change in intervention coverage, tempered by the effectiveness of the intervention in averting mortality, and apply that to the baseline kind of envelope of potentially preventable deaths. So we apply the change in coverage of each intervention along the continuum of care. So in LIST, you can't avert or cause a death twice. So the impact is attributed by step in the continuum. So preventative interventions have an effect before curative intervention. So for example, if a pneumonia death is averted because of an increase in vaccination coverage, that life can't also be saved because of the scale up in antibiotic coverage. Next slide. So then we take that model and compare it against a counterfactual, which is often a scenario in which there's no change in intervention coverage, or the change follows historical trends. And so we can compare our estimate of deaths or lives saved in both of the models, and that difference can show us the impact of specific interventions on mortality. Next slide. So I'm now going to hand over to Tim, who's going to take us through some of the methods and results for this specific analysis. Thanks, Tim.
Okay. Hi, everyone. My name is Tim Robertson, and I'm a colleague of Emily's at Johns Hopkins. So I'm going to go into a little bit more detail now about how we thought about this analysis and set up some of the values that we put into LIST. So what you're seeing here is a logic model or a kind of framework for how we think the pandemic on the left will affect or increase maternal and child mortality on the right. And some of you may recognize parts of this from the paper. There was a figure in there in which we put a similar kind of simplistic framework, and we've just expanded it a little bit here for clarity. So broadly speaking, there are two pathways, which you can see here. So on the top, we're imagining that the pandemic will affect a set of health systems components, the availability of health workers, supplies, and demand and access to health services. And we're imagining that disruptions to those components will in turn lead to reduced provision and utilization of health services, leading to reduced overall coverage of health interventions. And that reduced coverage of health interventions, mums and kids not getting health services at facilities, that will lead to an increase in maternal and child mortality. So that's the first broad pathway. The second is at the bottom here, where we're imagining that the pandemic will contribute to factors affecting undernutrition that could be through the health system or perhaps largely outside of the health system. So for example, the pandemic will reduce household incomes in many countries, will disrupt food systems and social safety nets. And that those broad factors will combine together to increase the proportion of kids who are wasted, who have low weight for height. And that because of that increased prevalence of wasting, you will see then an increase in child mortality, not because that kids die of wasting itself, although some may do, but largely because wasting increases the risk of dying from infectious diseases. So wasting does have a big impact, but just indirectly by increasing the risk of death from other diseases. So those are our two main pathways there. And I want to unpack each of those a little bit now. But before I do that, I'll draw your attention to this right side of the model. And what you see here is that I've isolated the parts of our model or logic that you can model in LIST. So those of you familiar with the LiveSafe tool or LIST know that it is a tool to model changes in mortality based on changes in coverage of health interventions and changes also in wasting and stunting. So this bit here on the right, that reduced coverage of health interventions that we're imagining under the pandemic and the increased prevalence of wasting, we can put those numbers into LIST, and LIST itself will model the effect then on maternal and child mortality. Further upstream in our model, we have the sections of our framework or thinking, which I think of as our assumptions, or these are the scenarios that we created to think about how the pandemic would eventually lead to reduced coverage and increased wasting. So these are numbers that we developed ourselves. They're largely speculative. They're a product of our hypothetical scenarios. So unlike LIST, which has actual evidence-based numbers for the effectiveness of interventions and actual empirical data on existing baseline coverage and all of that, and model that. This section here, all of the numbers and the thinking here are things that we developed ourselves just for this analysis. So, and I'll talk now about what that means for each of the two pathways. So our assumptions for how health systems would be disrupted are largely captured here in this little model. And you can see we've taken 4 health system components, like I said, and we're just saying very simply that these 4 components, or a disruption to these 4 components, will combine to produce a reduction in overall coverage of health interventions. And so what we did for our assumptions is we set reductions for each of these components, and then we took a very simple multiplicative equation or calculation and combined those reductions together to get an overall coverage reduction of health interventions. Now we recognize that that is very simplistic, and actually that there are in reality interactions between these things, and there are many other factors that contribute to health systems disruption or contribute to coverage of interventions. But for our purposes, this is the model that we took. Now, when I say reduced coverage of health interventions here, what I actually mean is reduction in a number of different health interventions. In LIST, there is over 70 individual interventions that you can enter or manipulate. And we included most of those, but not all. We think about it in terms of intervention categories. And as Emily said, most of the categories are along the continuum of care. So the categories that we included in our model were around family planning, antenatal, childbirth, and postnatal care, vaccinations for young kids, and early childhood preventative and curative interventions. And we also included increased wasting. So these are the things which we put into our projections, or we put changes into our projections. And again, these are categories, and even these categories themselves represent individual interventions. So for example, different individual interventions under antenatal care or childbirth, the administration of uterotonics, anticonvulsants, et cetera, et cetera. Some people asked if we included everything or not. I point out here, as we say in the paper, there are some things that we didn't include, or we didn't include changes for, namely changes in wasting, in WASH interventions, and in HIV. And the reason we didn't include changes for breastfeeding and WASH is because we assumed that there would be minimal change to those things. Others have since said, well, actually, maybe there will be a reduction in exclusive breastfeeding, or maybe there will be a reduction in WASH or other services. And we could certainly go back and incorporate some of those other assumptions into future models, but we didn't do that as part of our initial analysis. Likewise, we didn't include any changes to coverage of HIV interventions for kids because delivery of HIV interventions, preventative and treatment is more complex than other interventions. And also the global burden of disease among kids for HIV is quite small and really only located in a handful of countries. And this was a global analysis. So for all those reasons, we thought best just to exclude HIV. Though again, in future analysis, we do want to include updated, robust assumptions for how HIV coverage may change. One other factor I wanted to point out here is that you may be thinking ahead to say, well, if you are reducing coverage of family planning, then that will potentially increase fertility, and then you will see population growth. And merely because of that population growth, we may see an increase in the absolute number of kids who are dying. And that is true, but we did not include those numbers in our results. So we assumed that population would stay constant. And that was mainly for simplicity, and also considering the timing of things, we wanted to talk about deaths that would occur in the short term. So this would obviously take place in the longer term. And I'll just point out that I made a mistake here. That should say increased deaths due to population growth due to reduced contraceptive prevalence. Finally, we didn't include any changes to stunting because we assumed that while there may be some effect on stunting, that again wouldn't happen in the short term. Stunting itself takes longer to be seen, and then would only then start to have an impact. So since we wanted to talk about what would happen the next month, 3 months, 6 months, we didn't include stunting for that sake. I want to now talk briefly about this second pathway that we considered as part of our analysis, and that's the pathway around wasting. And you can see here, this is a very simplistic model at the bottom here. We're basically saying that a number of factors will be affected in terms of agriculture, food systems, safety nets, and even the health system. And that those factors will then lead to an increase in wasting. While there is evidence that that connection does exist, and in fact, I think IFPRI is doing an analysis now of looking at different GNI values for different countries and its association with wasting. While there is some evidence for that, we don't have a fantastic model for that, just simply because it is very complex and there are so many factors and what have you. So what we did for our analysis is that we entered a number for wasting itself. So whereas for the health system pathway, we assumed changes in components and then multiplied those to get a change in reduced coverage. For wasting, we simply assumed a relative increase in wasting for each of our scenarios. And for those of you who are familiar with LIST, you will know that within the tool, you can manipulate wasting in two ways. The first option that you have is to put in changes in coverage of interventions that affect wasting. So for example, we could have put in a change to SAM and MAM or complementary feeding. We could have shown that coverage of those would decrease, and that then would lead to an increase in wasting, and then that would lead to an increase in mortality. So that's the first option, to do it through interventions. We chose not to do that because we believe that would only capture a portion of the increase in wasting, whereas we imagine a lot more increasing wasting due to these other kind of factors affecting undernutrition outside of the health system. So that's kind of option two. But for option two, the only other choice there is to really enter wasting directly, because as I said, we don't have any models at hand to sort of model increased prevalence of wasting based on upstream factors. So this was our second option, and this is what we did. We simply put in an increase in wasting. And so for our scenarios, scenario one, our least severe, we assumed a 10% relative increase in the prevalence of wasting. For scenario two, 20%, and for scenario three, 50%. So that's kind of the thinking and logic behind our assumptions and what we did with LIST. We want to say though that as I'm sure you are thinking, in reality, all of these pathways are much more complex. We chose this somewhat simple model just to enable to get our heads around it and have some clear thinking around what would happen. But we could say that in future analyses, we might want to think about interactions between these various components, and also just including more factors and considering kind of more dynamics that are at play. Excuse me. Okay, I want to, in the next 3 slides, just talk briefly about the different scenarios we set up. So we set up 3 scenarios from least severe to most severe. And for each scenario, we took our 4 health systems components, which you can see there at the top: the workforce, supplies, demand, and access. And for each of those components, we assumed reductions for each intervention category. So our intervention categories are on the left here. And you can see that in this first scenario, we applied small reductions to all of the components. This was our kind of base assumption. Let's just assume that things are going to be disrupted everywhere to at least a small extent. So we've put in all of those reductions. We did try to be a little bit more nuanced than applying a blanket reduction to everything, just to capture the fact that, for example, for the workforce components, there are interventions which do not need a skilled health worker necessarily. So, we could imagine that women might purchase their own contraceptive and use that without needing a health worker, or likewise, families might buy ORS at a pharmacy and use that without a health worker. So we assume that certain types of interventions might not need skilled health workers. And in the demand column, we assume that there would be varying degrees of how the pandemic would affect people's demand for care. And we assume that for some interventions, they might be more elastic in the sense that, as people are thinking about whether or not they should go to the health facility to get that care, for some interventions, they may persist and still go despite any challenges or barriers. But other interventions, they might decide, well, actually, I'm not going to do that. And we again, these were speculative assumptions, and we didn't go into too much detail on that. Rather, just to say that the demand, the effect of the pandemic on demand might be different for some interventions compared to others. This is scenario one. As you can see, small changes. In our second scenario, we assumed that there might be further disruption on the supply side. So, for example, health workers might get overwhelmed by responding to the pandemic, that there would be supply chain issues, and that therefore you might see more moderate reductions on the kind of the provision side of things. And then in our third scenario, we imagine even further disruptions, perhaps around access, thinking about what might happen if governments instate, strong movement restrictions. People aren't able to get to facilities. People may not be able to afford to go to pay for services. And also this might affect health workers themselves, not being able to travel, not being able to get to health facilities. So For that reason, we increased access and the workforce components here heavily for scenario 3. And as I said before, for each of these scenarios, we just took a multiplicative equation to calculate our overall coverage reduction on the right for each of the intervention categories. And for each scenario, we identified a relative increase in the proportion of kids who are wasted. Again, even though there are only 7 categories of interventions here, in LIST we have upwards of 70 interventions. So for each of these categories, we applied that coverage reduction to the individual interventions. And I'll say that the baseline values for coverage for each of these interventions were country specific. So within LIST, we have all of the data from the most recent DHS surveys, mixed surveys, other sources of data. And we have the latest coverage estimates for various countries. And so, for example, in Nigeria for ORS, there is a certain coverage value, and we took that country-specific coverage value, but we applied a global coverage reduction based on our scenario. So if in Nigeria, ORS was a certain percentage, we took that individual country's percentage for that intervention in country, and we applied the reduction shown here in our scenarios. Okay, if you are familiar with LIST, you'll know that you calculate projections for an individual country. There are some features of LIST that enable you to do multi-country analysis, which essentially just run LIST for a lot of individual countries and then aggregate, or then you can use those to then aggregate the numbers. So if you're not familiar with them, you can use Scenario Generator in LIST and also the Extract tool. And these combined make it a lot easier rather than running LIST projections for every country and then manually kind of combining everything. If you're familiar with LIST, you'll also know that changes are put in by year. So we put in a baseline year and a kind of after or pandemic year. And then we took the additional deaths for that 1 year divided by 12 to get per month numbers. But then we did some slight modifications for some interventions, for example, to attenuate the impact of vaccine coverage reductions, because we imagined some protection in the short term from herd immunity for some vaccines. Okay, I don't think I will spend too long on the results in this presentation. If you're interested in the results, I'd encourage you to read the paper. It's available open access. But what I'll do here is I'll just briefly go over the main points in case it helps. So what you see here is we created these bar charts showing the current numbers of kids and mothers who are dying per month already. So this was before the pandemic, and that's the blue bars here, what we're calling baseline in this case. The orange additional stack bars, that's the additional deaths that would come about because of the reductions in coverage of interventions and because of the increase in wasting. So for maternal deaths on the left, we're imagining up to a 38% increase in the number of deaths per month, maternal deaths. And then on the right, child deaths, we're imagining up to a 44% increase in child deaths per month. And you'll see here we've separated out the deaths due to reduction of intervention coverage and the deaths due to increase in wasting. The numbers are presented in table format in the paper, which you can look at if you are interested. So what I showed here was these kind of aggregate numbers talking about the overall additional deaths. I think this is, we would consider our main finding or our main kind of results. And I think this is already serving a useful purpose in terms of raising people's awareness of the potential indirect effects, around advocacy for the need to consider disruptions and what that might mean, the costs of that in terms of public health. A kind of secondary finding or analysis is how individual interventions will contribute to those additional deaths if coverage of those individual interventions are reduced. So again, if you're familiar with LIST, you know that you can get intervention-specific lives saved or additional deaths. And what we've done here is we've calculated those deaths for each intervention, and then we've sort of put them in order. So at the top here, you can see that for maternal deaths, the perinatal administration of uterotonics, if that service, that intervention, if coverage of that intervention was reduced as it is in our scenario, in this case, scenario 2, then you would see a certain number of deaths. So 1,000 deaths per month due to the reduction only of that intervention. And then likewise for the administration of antibiotics, anticonvulsants, and clean birth environments. This ranking is a little bit hard to interpret. I think you need some caution in how you look at these results because it's a combination of several things. Firstly, it depends on what the baseline coverage is of each of these interventions in specific countries. So if you're wondering, for example, why certain interventions lower in this ranking don't have as many additional deaths, it may be that coverage of that intervention is already very low. So any reductions to that coverage will not contribute great additional deaths because coverage is already very low. People aren't being saved by that intervention in great numbers to start with, if that makes sense. Obviously, the higher the baseline coverage is, the more reduction you get because our reductions are relative decreases. So that's one thing. The second thing is the second factor that's driving these rankings is the reductions from our scenarios. Now, by and large, our reductions were similar across all interventions, but there were some slight differences here, which is captured as part of this ranking. And then the other big factor here is, well, how effective each of these interventions are in preventing deaths and which cause of death are they acting on. So some interventions are highly effective at a certain cause of death, but that cause of death does not account for a large portion of maternal or child deaths in a country to begin with. So I say all that, it can get quite complicated, but just to sort of say that, you know, this table requires careful interpretation. But if you're thinking about some global message from it, I think, as we say in the paper, that for interventions delivered in childbirth, if they were to be reduced under our scenarios, would account for about 60% of all the additional maternal deaths in our scenarios. So I guess the message would be that, you know, mitigating reductions to those interventions will save the most number of maternal lives, you know, who might otherwise have been lost if the scenarios would have come to pass. We can do the same also for child interventions, and you can see here that in our kind of listing of child interventions, that the increase in wasting would account for about 20% of additional child deaths, and 3 other interventions would account for 40%. So these are curative treatments for kids with neonatal sepsis or with diarrhea. Okay, what's our interpretation? Well, you know, as I said before, our primary aim here was just to sort of give some sort of ballpark reference point numbers for decision makers in terms of what might come to pass if health systems are disrupted and if we see an increase in wasting. And I think our results show that if those things were to happen, health systems, food systems were disrupted, then we'd see significant numbers of additional maternal and child deaths. If policymakers are thinking that they want to prioritize certain interventions, then I think our results give some idea of the sorts of interventions and treatments that might prevent that mitigation of reductions to those interventions might save more lives than others. But as I said, we sort of encourage people to think carefully about what those listings mean. But I think even a priori, without this, we can think that escaping the need to deliver those interventions at a certain time for all members of the population. So for example, childbirth care, you know, mothers need that at a certain time, and it really does save maternal lives. So that's sort of one set of interventions that one can think about prioritizing. And the same for child mortality. In our scenarios, at least, childhood wasting accounted for 20% of additional child deaths. Again, the assumptions for wasting were largely speculative. You could imagine that potentially even more wasting might occur, in which case you would get even more child deaths, and it would account for an even greater percentage, or it could also perhaps not be as severe. I think I've talked through some of the limitations as I was presenting, but again, these are not meant to be estimates or projections of what will happen. Rather, our analysis was saying, if these reductions and increasing wasting were to be seen, then you would see certain numbers of additional maternal child deaths. Or if this other thing were to happen, then you would say this. All of our assumptions, they're scenario based. And again, we started this analysis quite early on in the pandemic. Early on to where we are now. So we started, for example, in March, April, when we hadn't yet seen a big impact in low and middle income countries. So our thinking was based on what was happening in high income countries. I think in future analysis, we want to have more robust assumptions around what is actually happening in specific countries, and specifically in low and middle income countries. LIST itself has some limitations. It has many interventions that you can manipulate, but they're health systems, health sector interventions. It doesn't estimate the effect of changes to incomes, agriculture, or food markets. And it also doesn't capture the kind of infectious disease dynamics, for example, potential secondary outbreaks, things that you can capture in other dynamic models used to estimate kind of changes to vaccines. And as I said, I think before, we presented our results for reductions in a certain time period, so 3-month reduction, 3-month disruptions or 6-month disruptions, and the deaths that we reported were for deaths during that period. I think we all agree that it may then, even if the reductions only last at full strength for 3 months, there will be a period in which things are returning to baseline. There will be lingering effects, and we didn't capture that in our analysis. Okay, I think I've got maybe 2 more minutes, and then we'll open up to questions. But before we do that, I want to say, just give some thoughts around where we see potential future analyses sort of heading. And we've got 2 paths forward. The first path for us, I think, is to refine this current analysis and update it with more robust assumptions, specifically assumptions that are country specific or more kind of relevant to how countries themselves are responding to the pandemic. We also are working with different expert groups around nutrition, family planning, and HIV to incorporate some of the assumptions that are perhaps developed more robustly by other groups, trying to incorporate them into our own model so that we have the kind of the best assumptions that we can for each of these different types of interventions. We can also think about doing subnational estimates, which is a possibility with LIST, thinking about potential variation in how parts of a country are disrupted, and also think about longer term impacts or creating trends of disruption rather than just our kind of block short-term reductions that we did in this analysis. The other general path forward that we see is to start to do modeling and estimates around what is actually happening in countries. So rather than scenarios, sort of hypotheticals, we now start to take real data from countries using, for example, data from HMIS systems or maybe rapid surveys or assessments, and saying, okay, and taking the actual reductions that we are seeing around coverage or utilization of services and incorporating that into a model. So I think where many people are kind of eager to do that as soon as possible. I think we may need to wait until we actually get data of sufficient quality to do that, but that would be one way forward. And so rather than sort of analyzing the what ifs, we can start to think, okay, well, this is actually what we have seen, and maybe even using that to project forward for the rest of the year or things like that. So they're the 2 kind of ways forward we see for future analyses. Okay, this is my last slide. Just to say, I think some of you might be on this call because you got our message through the LiveSafe Tool email listserv. So you may already be familiar with LIST, but I think there might be others here who aren't familiar with LIST. If you have never used the LiveSafe Tool before, I encourage you to maybe try using it. We think it does take some kind of learning to be able to use it, but it is not a significant barrier. And in fact, we've tried to put many resources available online that you can use to maybe get started with LIST. The software is free to download. It comes with all of the default data that we have for all of the countries. So you will immediately have the data that we ourselves use to run different country projections. In addition to our actual website, we also have a YouTube page with about 30 or so different videos that you can watch, tutorials or examples where you can see us creating our own projection. And some of them are only 10 minutes long, and hopefully if you were to watch those, you'd see that that is actually very doable. You know, you could easily take it and do that yourself if you wanted to. We think there's a lot of potential for people in particularly doing country-specific analyses to take a list and to maybe put in their own country assumptions or their own estimates of what they see happening in a country, and to model projections themselves. And we would encourage everyone who wants to go ahead and do that. We have limited bandwidth, but we are, I think, ready to help people do that to a greater or lesser extent if people need support. And lastly, if you want, you can also take our own projections that we did for our analysis, and there's a link here to a Google Drive folder. We've put all of our list projection files there. So if you want to start on your own analysis, but you want to start from kind of what we did and maybe tweak it or modify it, or even just look at the kind of things we put into our own projections, then you can take the files there, open up list, open up these files with list, and you can see exactly what we did. And as I said, use that as a starting point for yourself, or maybe to get ideas for your own fresh analyses. So just want to finish by thanking you all for coming and joining us in this webinar. It's been fantastic to have so much interest in this study. The LiveSafe tool receives a lot of funding and support from the Bill and Melinda Gates Foundation. Also recently had additional support from Global Affairs Canada. So we thank them for helping to maintain, or helping us maintain LIST up to now and hopefully into the future. And I also want to thank any colleagues from WHO or UNICEF or World Bank who are on the webinar here, who have helped us develop some of our assumptions for this first analysis, and are helping us to think through, you know, what we might do going forward. So with all that, I think we've got time for at least 15 minutes of questions. And I think even though we may have said that the webinar finishes at 10, we actually, I think, are available to stay on the call for another 15 minutes after that. So hopefully we can answer your questions now. Thanks.
Thank you, Tim and Emily. So we have gotten a couple questions from the chat, and there are a few that have been answered, clarifications, et cetera, that have just been answered in the chat question and answer window. But we just wanted to bring a couple of the larger issues up. And the first question Tasneem had was, we are thinking of doing country level analysis. Do you think that it is needed, or is the analysis that you've done sufficient? Are there any additions that you would like to suggest? So, I'd open that up to the study authors to see, is there anything, what do you think in terms of where we are now versus whether this is sufficient, and how would you carry it forward?
Mm-hmm. So absolutely, we would see a kind of need to do country level analyses. We have country specific results, and if you look in the supplementary file or the appendix to our paper, you can see those results. We didn't present them in the paper itself because we're reluctant to put country-specific numbers when the true reality in countries is like to be very different. So in LIST, we took country-specific baseline values. We have country-specific cause of death values, but we are applying our scenarios to every country in the same way. And so that's useful for this kind of, I think, preliminary analysis. But as for countries, particularly countries where you're starting to see what is actually happening, and you could perhaps put in more nuanced assumptions or nuanced scenarios, then I think maybe it's worth going back and starting again on country projections.
Great. I'm going to also pivot to another question Bill Weiss had asked about, any discussion about how we could potentially use crowdsourcing tools, such as some of the Google mobility reports that are now available by country. What are your thoughts about using that as opposed to also using other data sources? So either Emily or Tim, if you wanted to answer that one.
Tim, I think you had some ideas around use of HMIS.
Yeah, I think so crowdsourcing or novel kind of methods for estimating kind of population movements, I think are very interesting. I think for us, what we need is to translate any data that we get into coverage reductions. So while we may have interesting data around how people are moving, going to the supermarket, that kind of thing, we need to be able to translate that into kind of coverage change. Like, are people actually going to the health facilities? And then, you know, even when they get to the health facilities, do we have the treatments there, the health workers there, so that they can get care? So I think there are some jumps you need to go from kind of novel data to that. Now, crowdsourcing actual health information data, or even just using government health information systems, DHIS2 platforms or other things. Yes, absolutely. I think routine data is a really potentially valuable source of information for us. And maybe not now, or maybe at the end of this month or the end of the second month, we're going to see that you know, we can create trends from our routine data where we see a sudden reduction in March, April, or May. And again, even though that itself is not coverage, because routine data, HMOS data, the denominator there is different from population coverage because it's only people coming to a health facility. I think you can apply reductions in utilization, or that kind of numerator. You can apply reductions around the numerator to another existing kind of gold standard source of coverage. So I imagine using DHIS platforms to get reductions. And again, it could be around categories of interventions, and then we map those categories to specific interventions. Using DHIS2, those reductions in combination with, you know, our DHS or mix or other coverage best estimates to kind of estimate the new coverage under the pandemic. So that wasn't extremely clear, but all that is to say that I think there are lots of options there.
The next question just had to do with sort of timing. So Booty had said that she hasn't used List, or he or she hasn't used List in a while, but our projections or this paper frames coverage reductions in terms of months. And for other work, or more commonly, you see the LiveSafe tool being applied for a multi-year strategic planning approach. So Emily, did you want to address the timing and how that was handled in this paper?
Sure. So yes, LIST typically looks at annual periods. So for this analysis, we took a very simplistic approach of just kind of dividing that kind of annual impact by our different windows in which we envision this could play out. That being said, as I mentioned, it's a very simplistic approach, and we know that the pandemic, there'll be a period of transition where things get worse and then where things get better. It's not a hard start or stop. We didn't model that explicitly, and that's something to think about with future analyses or when thinking about how this will impact on individual countries. So yes, that's how we took the.
So one of the questions had to do, Molly was interested in, sort of surprised by the findings about the low contribution of ACTs for malaria, given the relative contribution of oral antibiotics for pneumonia and ORS for diarrhea showing up pretty prominently. And we wanted to compare and contrast that to evidence from Ebola about the increases that were reported for malaria-related deaths. So I think, how does this work sort of in the context of what has been known about post hoc from the Ebola work analyses?
Yeah, so one of the things that you see here is that this was a global analysis. So we're taking 118 countries. So part of the reason that you see that some of the malaria impacts are kind of lower in the tiering of kind of the global effects of interventions is just a product of the fact that, you know, you're limited to certain malaria endemic countries for that impact. So the contribution of mortality in India alone kind of brought those malaria specific impacts down. So if you're starting to look at a country specific level, in those malaria endemic countries, we would expect that ACTs would play out as being just as impactful as things like antibiotics and ORS, those other curative services. So that's one of the things to take into account when you're thinking through our global impacts versus what you would see at a country level.
And I had one question, this sort of relates to the changes in the prevalence of wasting. And the question was, how did you measure disruption in food systems? What indicators did you use? And what are the sources of data? Did you use changes in food prices? And I know that there's been, this is probably covered in the future work as well as current, but if you wanted to describe disruption of the food system related to this analysis, and then maybe next steps.
Yeah, I think this is of real interest to a lot of people. The nutrition community, I think, is very concerned with the effects of the pandemic on increased wasting or stunting or other aspects. I mean, I think we'll be completely honest. For this analysis, as I said, we just assumed that there was a certain relative increase in the proportion of kids who are wasted. We did no further upstream analysis to generate those numbers. Again, it was early on. I think we had virtually no data at that stage. I think there is still very limited data on what is actually happening. I think there are analyses and models that are now trying to look at, for example, food prices and access issues and incomes and economic situations to then show the increase in wasting. I think that's one really potentially way forward. Another is, I think WFP and others are talking about just doing more rapid anthropometric surveys or something. So I think going forward there are options there. Many people are interested in it. Many people are trying to work on it. But right now we haven't seen any, and even with all of us reaching out, we have had no one come and say, wasting will increase by this amount. And it is quite, at this stage, it's quite hard to get any reliable estimates. So for all those reasons, in our scenarios, we just picked numbers, and I think we very clear that those were just numbers, assumptions that we chose, and that it could very well be different in reality.
So I had two questions. One I was going to flag about baseline. So when is Anissa's asked, when is the start of the first 6 months? Is the date of the first official case of COVID reported in the country? Is there an estimation of mortality after the first 6 months? So the first question is just sort of about how we created the baselines. What do they reflect?
So again, this is a hypothetical scenario. So there's no set start or end date for a specific setting. This is just kind of taking different windows of impact. So this would think of your impact window as kind of a period of 6 months in which we think that reduction in coverage would be kind of consistent across that 6-month window. Again, we don't model kind of a scale up or a scale down of that impact, and we're not taking into account any sort of the longer term effects that we would anticipate, things like impacts on stunting going into the future, what would happen due to reductions in vaccination coverage, reductions in herd immunity going forward. So there's a number of kind of longer term effects that we didn't look at. We're just looking at those immediate impacts within defined windows of time.
So there was one question about the results, and Tim, could you answer how to disaggregate the neonatal deaths about how those neonatal deaths are calculated relative to the all under 5? Because that wasn't presented in the overall.
Yeah, that wasn't presented. Some people have asked that, and probably rightly so. I think so. We included all interventions that would that impact neonates, and all the sort of childbirth interventions and other kind of postnatal interventions. That's all captured there, and all neonatal deaths are within the child deaths that we estimate. We did not show or disaggregate those. I think because for two reasons. We wanted to just be very clear and simple in what we present, and that there's, I think, value in keeping things clear, the message clear. So that's one reason. And then the second is maybe, with all of our numbers, we're reluctant to be too precise or too just to create the impression that we were more kind of that we were more certain about certain things than others. And I think particularly around neonatal deaths, neonatal mortality rates, for example, there's more uncertainty there. So I think, shied away from that. But I think you're right to say that, we could have done that, and absolutely we could have done that. And I imagine that in future analyses, we will.
Yes, exactly. Because typically the LiveSafe tool is estimated, usually those are rounded, but because it's a mathematical model, it will give you to the units numbers. So those are presented in the tables. There are two questions related to immunization, vaccines as an intervention. So I'm going to ask Emily. The first is, what is the basis for selecting TT, DPT, and measles as the only vaccines used to project effect on child death? And then would it be worthwhile to conduct analysis for specific countries based on the prevalence of their child conditions? And the second one, which is related, is what is the baseline percentage related to including countries being protected by herd immunity? So I'll leave that to you in terms of what assumptions were made for countries like Nigeria, which that no assumptions, paper state, we had stated as one of the caveats that no assumptions were made for countries like Nigeria to have herd immunity because of low immunization coverage. So both the herd immunity effect and the selection of interventions, immunization interventions.
Yeah, so just to kind of clarify our assumptions around vaccines. So we included a number of vaccines in the analysis, tetanus toxoid vaccination during pregnancy, and then child vaccines, including DTP, pneumococcal, Hib, rotavirus, meningococcal A, and measles vaccine. BCG and polio are also included in the model, as well as Hep B, but they don't really have an effect on child mortality. So we attenuated the impact of vaccination coverage reduction for pneumococcal, Hib, and rotavirus, those three vaccines, on the assumption that large kind of population coverage would have an effect of inducing herd immunity. So that kind of temporary reduction in coverage due to stopping vaccination campaigns or reduced coverage in the kind of immediate window would have less of an immediate impact on child mortality because of that herd immunity. So some of the assumptions underlying that herd effect were that countries that had over 60% vaccination coverage would benefit from that herd immunity, and that countries with less than that would see little to no herd effect. Now, in reality, that kind of the herd immunity is kind of a sliding scale where we see increasing coverage tying to increasing herd immunity. We applied kind of a blanket global impact for that attenuation that I think was around a 30% attenuation in the reduction in coverage. So if you start looking at individual countries, you would need to go in and think about what their baseline vaccination coverage is for those three conditions and take that into account. For things like measles, where you have a very high R, we assume that the herd effect would only come into play at very high coverage levels. So we don't do any sort of attenuation there. The impact of measles vaccine is consistent across the board. There's no attenuation there. And that's kind of our approach. When you start thinking about, again, individual countries, the model does take into account the country-specific mortality and cause of death structure. So you have some countries, again, where measles might account for a larger proportion of the baseline mortality than other countries, and that does come into play with the way the LIST model is being run, because we are using that country-specific baseline information.
So we're going to pivot a bit to the nutrition interventions. There were two questions about nutrition as an approach. One is, what proportion of wasting deaths can be reduced through the health system? And then the second question was whether our assumptions related to breastfeeding, and would mothers, for example, be unable to breastfeed due to stress? So one is about proportion of wasting deaths that can be reduced through a health system is the first one. I'll turn it over to Tim to answer.
Yeah, so that's a good question. I think so the list, you either have to pick one or the other at the moment. You either have to put in an exact increase or decrease in wasting, which then disables the effect of other interventions on that wasting. In other words, you just put in the changes to wasting and then that gets moving forward in the calculations. Or you only model wasting or changes to wasting based on coverage of interventions. And for us, there are only three. There's SAM, MAM, and complementary feeding. I think we're all agreed that the contribution of SAM, MAM, and complementary feeding, like the reductions to those in our current scenarios would be equivalent to only about 10% of the overall reduction that we see from our direct change in stunting, in wasting that we put in. But again, those ratios are based on our own assumptions. So they're somewhat, it's sort of a bit circular in that whatever assumptions you put in, that'll end up being the kind of ratio. But I think the overall answer is that there will be, or we can model SAM and MAM, but our thinking is that changes via the health system through that will be largely outweighed by changes due to bigger macroeconomic factors, health system factors, etc. At least in this analysis. But then it becomes quite complicated because you could imagine, reductions, increasing wasting due to all these other broad factors, but then mitigation through SAM and MAM by increasing coverage of those things, and maybe potentially you could potentially equalize to some degree, depending on how you scale up coverage, because coverage is all of those kids who need it. The point is, currently it's a little bit hard to disentangle proportions or whatever, but we have made some starts on that and have done some initial kind of analysis on that. And I think if there are members of the nutrition community here on the call, I think we absolutely have started to do that and want to keep doing that going forward. So yeah, there's that.
The last question we wanted to answer is could you say a little bit more about what interventions might be recommended in each of the three scenarios? So either Emily or Tim, could we say a little bit more about how the interventions, the tables are presented that rank the interventions? Do you want to speak a little bit about how the model is estimating those tables and ranking those?
Yeah, I think I said a little bit about this during the presentation, just that those ranking tables are quite difficult to interpret, and they reflect maybe four different kind of drivers. Firstly, what is baseline coverage for that intervention in that country already? So if baseline is already low, then further reductions are not going to contribute many additional deaths. There's the actual reductions in our scenarios ourselves, and within one scenario, a lot of the interventions have the similar reductions, but across our scenarios, obviously we increase the reduction in scenario 3. They also depend on what causes of death those interventions affect. And for some causes of death, a smaller proportion of the overall maternal mortality is captured versus others. So interventions that act on causes of death that are responsible for a large number of deaths will have greater impact. And then there's the effectiveness of the actual intervention itself. Because it is complicated and because of all these factors, we're very reluctant to say that, given our ranking tables, countries should prioritize, X, Y, and Z. Although we do in our paper sort of highlight that childbirth care and child curative services would contribute, larger numbers of additional deaths if these reductions were to be seen. So I think we're reluctant to give advice or give, say, certainly I think countries need to do that with their own data and with their own country specific assumptions. Maybe the last thing to say is that even, before we had our table, I think practitioners can think about, the potential for some interventions to be either, for delays in those interventions to be quick short-term delays to be caught up by, for example, campaigns immediately after the pandemic. Also, maybe novel delivery mechanisms. Maybe there are some interventions that can be delivered, through other vertical programs, through telemedicine or some other way. But there's this other category of intervention where there's just no escaping the need to deliver that, when it is needed. So does that mean prioritization? Well, you know, I think that's for countries to say. But I don't know, Emily, did you want to add to that or anything specific around vaccinations for that?
No, just to highlight again, when you're thinking about this at a country-specific level, so to really consider, this was meant to be a hypothetical, various scenarios that we're kind of modeling out here. So when you're thinking about using it at a country level, think about, go through and look at those coverage numbers, make sure that they align with what you know to be true in your setting, and think about what makes sense for your specific situation.
So thank you. I think that we have received a bunch of questions. Again, we tried to answer as many of them as we could in the chat or in the window. And I think we answered a few online. If you have more questions, feel free to send us a question or reach out if you're unable to access the resources. As we mentioned, the analysis, the papers come out and is publicly available, free to download on Lancet Global Health. The supplement or the appendix of supplemental material presents country-specific informations that give you a good starting point for, based upon the assumptions which are made at a global level, individual impact estimates and coverage changes are presented in the appendix. And then lastly, our website, LiveSafeTool.org, as well as has both the information about how to use the software, how to use the model, documentation, as well as any other explanatory information. But feel free to let us know if you have additional questions. As Tim mentioned in his future slide, there are certainly going to be revisions and adaptations, I think, of this work moving forward as additional information becomes available. Hopefully those are country level estimates or country level trends, et cetera. But thank you for the sort of overwhelming turnout. We're really, really excited by this work and glad you could join us to hear more about it. So with that, if there's anything else, I'll for our lead authors, thank you for joining us, and we'll hope to stay in touch. Thank you.